you were looking at vemurafenib plus cobimetinib. Can you tell me about the Co-BRIM study, what it is you did and what you found?
Sure. In the Co-BRIM trial, so we compare the combination of anti-BRAF and anti-MEK, vemurafenib and cobimetinib, with vemurafenib alone. And I presented very recent data from January 2015, so confirming that we have a very important percentage of good results with more than 60% of complete and partial remissions. And another important thing is that we increased to 16% of complete remission. So definitively it shows that the combination has better results than using vemurafenib alone with a prolonged duration of the response.
Now, is there a downside, though, in terms of toxicity from using this combination?
Yeah, I think it's the problem of adverse event is an important question. And we have first an increase of phototoxicity. The second thing is that we have serous retinopathy, but the opposite, we have a decrease of squamous cell carcinoma.
What's your verdict then on using this combination of targeted therapies? Is it now to be recommended?
Not still, because so we need to have the approval of our agency, but I think that probably in the future it will be discussed as first line probably in patients with BRAF mutations.
And how does this fit in with the first line therapy with immunotherapy, for example?
It can be discussed, but I think that probably one of the most important things will be the speed, the rapidity of the evolution of the illness. I mean, when you have a quick evolution, BRAF positive, probably the Co-BRIM has to be firstly discussed. But you're perfectly right. The place of anti-PD-1 can also be discussed, but probably less in patients with high tumor burden or a very quick evolution. Probably, I think that Co-BRIM will be most interesting in first line.
So could you sum up for busy cancer doctors, what are the clinical messages briefly coming out of your study?
For patients, so BRAF positive in the future, so we probably have to discuss as first line the use of Co-BRIM with longer duration of responses and more complete remissions. And so just to check about adverse events, it is always the problem of the ratio benefit-risk.
Of course, we're still waiting for licensing in certain ways, aren't we?
Absolutely, probably in 2016.
So what do you think is the message for current practice? Is it to watch this space, or are there things you can apply now?
Just that now we can say that we have a manner to with the combination therapy, so we have a manner to avoid the problem of the resistance that we have with MEK.